Good afternoon. This is Chapter 6, Lower Limb. This is going to go over the introduction to the chapter, the anatomy, and the positioning of the toes and foot. This comes from the 11th edition of the Textbook of Radiographic Positioning and Related Anatomy, and this chapter begins on page 212 of your book. When we look at the lower limb, this here is figure 6.1 on 212. Basically, over the next 2 weeks, we will be looking at the entire lower extremity along with the pelvis. So we'll start at the foot, then go to the lower leg, the femur, hip, pelvis, and that is basically going to cover the next 2 weeks of this class. So I'm going to break down the lectures like we've been doing so that it's a little bit smaller chunks so that it's a little bit easier to understand and learn the positions. Now, since you've already learned the upper extremity, I do feel that lower extremity goes a little bit quicker because you're not having to learn everything. You're just switching out the names for the different bones. So when we look at the bones of the foot, we still have phalanges or toes or digits. There are 5, starting with the big toe or the medial digit. That would be referenced as number 1, just like the thumb was on the hand, and then 2, 3, 4, and 5. Each phalange has a phalanx or multiple. So the first digit has 2 proximal and distal phalanx, and then digits 2 through 5 have a proximal, a middle, and a distal phalanx. Just like with the hand, each phalanx has a head, a body, and a base. And then instead of metacarpals, now we have metatarsals. Again, 1 through 5, each has a head, a body, and a base. And we have 7 tarsal bones, whereas in the hand we had carpal bones, and there were 8 of them. So total bones in the foot, we have 26, 7 tarsals, 5 metatarsals, and 14 phalanges. Okay. So when we look at this 5th metatarsal, there is a tuberosity at the base of the 5th metatarsal, and that comes into play when we talk about positioning because that is a very common fracture site in the foot. This picture is referenced on page 212, figure 6.2. When we look at the joints of the foot, again, they are very similar to the hand. You still have an interphalangeal joint in the first digit. We have distal interphalangeal joints and proximal interphalangeal joints, just like we did in the hand. Instead of a metacarpal phalangeal joint, now we have a metatarsophalangeal joint, or your MTPs. Between the tarsal bones and the metatarsals, now you have tarsometatarsal joints. And then they're showing you that both in a dorsoplantar view and in a lateral view. And this comes from page 213, figure 6.3. When we look again, we have sesamoid bones in the foot, but interesting enough, in the foot, they're actually named. Typically, you have 2 sesamoid bones. They're extra bones that are embedded in certain tendons, and they're often found near joints. So we have them in the hand. They typically are found in the palmar surface near the first digit or in the thumb. And then in the lower limbs, they tend to be larger and more significant radiographically. You can actually fracture your sesamoid bones in the foot. So these have a name, and they're named by the bones of the lower leg. So the medial sesamoid is the tibial sesamoid, and the lateral one is the fibular sesamoid. Just like the medial bone in the lower leg is the tibia, the lateral bone is the fibula. So these are the tibial and fibular sesamoid bones. The tarsals, like we said, now we only have 7 tarsal bones instead of 8, and these have a mnemonic as well. This is on page 214. And the mnemonic for this is come to Colorado next 3 Christmases. So you have a calcaneus, which is an odd shaped bone. When we look at that on its own, we will look, it is a strange shape to the calcaneus. We have a cuboid, 3 cuneiforms, excuse me, whew, long day, a navicular, and then the talus. Okay, and when we look at the mnemonic for that, the mnemonic is come to Colorado next 3 Christmases. So come would be the calcaneus, talus is 2, the cuboid is Colorado, navicular is next, and then the 3 Christmases is the 3 cuneiforms. All right, so come to Colorado next 3 Christmases. So those 3 Christmases, or the 3 cuneiforms, those are called by either of 2 names. You can refer to them as first, second, and third cuneiform. First is always the medial or most inward, then second is intermediate, and then the lateral one is third. You can also refer to those, like I just said, as medial, intermediate, so a medial cuneiform, an intermediate cuneiform, and the lateral cuneiform. Okay, so first, second, and third, or medial, intermediate, and lateral. And again, that is looking in a dorsoplantar or AP view. This is on page 215. And then you can see in the lateral view, we can see those as well. All right. When we look at the arches of the foot, there are 2 arches of the foot. We have the longitudinal arch and we have the transverse arch. Okay, so the longitudinal arch is referenced here. The longitudinal arch is the long axis of the foot, and you can visualize that laterally, so looking from the 5th digit side, or you can look at that medially. So this kind of, usually they reference this when you think about it, if somebody has high arches or if they have flat feet. If they're considered flat foot, then they usually don't have much of a longitudinal arch, especially when you look from the medial aspect. Okay, so when we do feet and we have to determine the angle on the tube, we want to view the arch from the medial side of the foot, meaning the first digit side, not from the lateral aspect, because it would always represent much flatter than it does from the medial aspect. So that is the longitudinal arch. The transverse arch would be is if you were looking from the patient's toes towards their ankle. That's where you would visualize the transverse arch. All right, that doesn't really come into play so much with us and positioning. We tend to focus more on the longitudinal arch. Some anatomy to look at in this radiograph. You can see I've gone ahead and labeled them for you. So A right here is the tibia, B is the calcaneus. Notice how large that is. C is the calcaneal tuberosity, D is the cuboid, E is the tuberosity at the base of the 5th metatarsal, F is the superimposed cuneiforms, G is the navicular, H is the subtalar joint right here. That is the subtalar joint, and this is pointing to just the talus. So that is referenced on page 217, figure 6.13. Now, I won't read through all of these, but this is actually the 30 to 40 degree medial oblique foot. This is all right foot. Notice I labeled it all right, and then each letter corresponds to all the bones that are found in the foot. So that is definitely something that in the last image, you definitely want to make sure that you are looking at that and understand the concept of all of those anatomic areas and where they're found radiographically, as well as on a drawing of the foot. Again, page 217. The joints of the lower limb. There are several joints in the lower limb. We mentioned the interphalangeal, both proximal, distal, and just interphalangeal. We've also got metatarsal phalangeal, tarsometatarsal, intertarsal joints. You've got the ankle joint, the distal tibiofibular and proximal tibiofibular, just like radioulnar, proximal and distal. And then you've got your knee, and also there is a patellofemoral joint between the patella and the femur. So again, joints aren't really um, hard, because typically the name of the joint tells you where that actually falls on the anatomy, like what two are connecting or helping to form, what two bones are forming that joint. When we look at the surfaces of the foot, you have the dorsal surface or the dorsum, which is the top or the anterior portion of the foot. I'm trying to correlate this to a page in your book. I am not sure that they actually put this in here. Oh, no, no, yes. Page 223 has both that last picture that we referenced with the joints, that's in 6.35, and on same page 223, 6.36 and 6.37 are both going to be looked at. So as far as the surfaces, okay, you've got the dorsal surface or the top of the foot, the anterior surface, and then underneath we have the plantar or posterior surface. Okay. Notice that they're telling you when the central ray is up here coming in this direction, it is considered an AP or a dorsoplantar projection. Either one is acceptable. If it's AP, it's coming from the anterior surface, exiting posterior surface, because that's what projection talks about, is the path of the central ray, or you can call that a dorsoplantar projection. If the central ray was coming the opposite way, then you would reference it as a posterior-anterior projection or a planto-dorsal projection. Okay. And then these movements right here are actually on the next slide. If we look at that, you've got the motions of the foot and ankle. So this is considered dorsiflexion when you're pulling the toes back towards the lower leg. And when you're pointing the toes downward, that is considered plantar flexion. Inversion is where you're turning the foot inward, you're inverting it. And eversion is where so this one you're coming more towards the middle with your motion, and eversion is going away from the middle. So it's also referred to as varus and valgus. Okay, and that's 6.37 on 223. So inversion, this one, or varus, is where you inwardly turn or bend the ankle and the subtalar joint. And eversion or valgus is where it's an outward turning or bending. If you're doing inversion and eversion, then the lower leg does not rotate. Okay, and they reference typically that most sprained ankles occur when there's forced inversion or eversion. So think about when a patient, accidentally steps in a hole in the grass and then they fall sideways. A lot of times that would be when their foot stays planted and they fall like that. It's a forced eversion or inversion, depending on which way they fell. That's typically what happens. When we look at some of the technical and positioning considerations on 224, most lower extremity, as along with upper, are at a 40-inch tabletop. Gonadal shielding is listed on here because the registry and the ARRT still recognize that shielding is applicable, even though most of our sites do not use gonadal shielding, and it's been proven that it can be more harmful than good. Until the ARRT recognizes it and it's removed from the registry, it still is considered to be done and taught, even though we know that that is not the case in field. Ideally, you're going to have four-sided collimation, just like we did with the upper extremity. You always want the correct part in central ray alignment, and ideally the part is parallel to the IR, and your central ray is perpendicular to both the part and the image receptor. And as always, you want a proper anatomic side marker placed prior to exposure. Annotating is not acceptable in any way, shape, or form. The KVP range, 65 to 75, would be acceptable. Short exposure time, small focal spot typically until we get into the grid, and then that would change. An adequate mass, and any anatomy that is over 10 centimeters in thickness ideally would be using a grid and move to the table bucky. We do have, just to point out, we looked at it before, but on 225, we do have the cast conversion chart. And remember, with that, we're looking small to medium plaster cast. You're going to increase about 5 to 7 kVp. A large plaster cast is 8 to 10, and fiberglass is typically 3 to 4. Okay. I recognize the exposure factors when they're talking on 224. They tell you that KVP is between 50 and 85, but I would tell you honestly, with digital, I don't know of anywhere that would use less than 60, honestly, unless it was a pediatric patient. All right. When we look at the imaging of the toes or the digits or the phalanges, whatever you want to refer to those as is acceptable. That will begin on page 228 of your textbook. And when we look at that, let's look at this first one. So if they order toes, just like with fingers, typically toes are going to have 3 images, an AP and a lateral for all of them, and then they're going to have an oblique. But depending on which digit or which toe is going to determine whether it's a medial rotation oblique or a lateral rotation, just exactly like it was in the hand. Technique is nice because it's the same exact thing. So we're going to use 60 kVp at 0.8 mass for toes. And when we do an AP image of the toes, this is going to show you any fracture or dislocation, any pathologies like osteoarthritis or gout. All right, so 40-inch SID, you're likely to be collimated minimally to an 8 by 10 portrait. Even though the book says landscape, ideally the long axis of the part is still going to go with the long axis of the image receptor. 60 at 0.8, and as far as the part, you're going to do one of either two things. You are either going to angle the central ray 10 to 15 degrees towards the calcaneus. So this is an angulation of probably between 10 and 15 degrees towards the calcaneus, because you want to be perpendicular to the phalanges. Okay. Foot is a little bit different as far as being able to flatten it or not elevate, because we have a natural, because of the arch, the metatarsals are at an angle, which usually means that the toes are not going to be flat, so you have to angle the central ray to be perpendicular to the phalanges. If you don't want to angle that, then what you can do is use a 15-degree wedge and place the toes on that 15-degree wedge, and then your central ray would be perpendicular. So this is on page 228, and you're either using the sponge with no angle to your central ray, or more likely you're not going to use any form of a sponge because it can cast artifact. You're going to angle 10 to 15 degrees towards the calcaneus, and your central ray is to the metatarsophalangeal joint in question. Okay, so this one they are looking at a second digit. This is figure 6.40. This particular one, they have the wedge, so it's a perpendicular central ray. On the last image we looked at, they had it as 6.39, where they angled the central ray 10 to 15 degrees. If that is done correctly, then you will end up evaluating the digit and a minimum, notice it says distal half of the metatarsal. This is definitely enough because you can tell the metatarsal probably ends right about here. So that is actually a really nice image. So you have to demonstrate the digit of interest and a minimum of the distal half of the metatarsal. There should be no overlap of soft tissue. The interphalangeal and metatarsophalangeal joints should appear open, which they absolutely do. So you've got metatarsophalangeal joint here, and then you've got proximal interphalangeal joint and distal interphalangeal joint. And this is second digit. You can see the sesamoid bone right here, and since it's the one to the lateral, this would be the fibular sesamoid. The marker placement on there is not really that great. I feel like we can tell that it's a right, but if that was the case, I feel like I would have left the collimation open slightly more to visualize that right marker. After you do an AP of the toes, we're going to do an oblique, and it's 30 to 45 degree oblique, and it's going to either be medial or lateral rotation. Remember, with all the obliques, it's always a degree and a direction. So 30 to 45 degree medial or lateral oblique. When we look in the book on page 229, I would tell you that the first and second digit would be medial rotation, and third, fourth, and fifth would be lateral rotation. Okay, I know the book says first, second, and third is medial and lateral for fourth and fifth, but I would tell you that it's much easier to do lateral rotation for third, fourth, and fifth. Okay, so first and second, medial 30 to 45 degree, and third through fifth is 30 to 45 degree lateral rotation. Still at a 40-inch SID, still 60 kVp at 0.8, and the toes are still to run with the long axis of the IR. So with this, the patient will rotate their leg and foot 30 to 45 degrees medially, if it's the first or second digit, or 30 to 45 laterally. So this image here, this is medial. So first and second digits, medial rotation. Third, fourth, and fifth, lateral rotation. So coming towards the middle, going away from the middle. All right, and central ray is perpendicular to the metatarsophalangeal joint in question. If done correctly, then this would show the digit and a minimum again of the distal one half of the metatarsal. The interphalangeal and metatarsophalangeal joints should appear open. Notice it says you'll have increased concavity on one side of the shaft. The heads of the metacarpals should not be overlapped, and optimal exposure factors. So this particular image is a medial oblique of the second digit. So we're looking at this. All right. Joint spaces are relatively open, not all the way opened on that. When they talk about the digit in question, distal half of the metatarsal without overlap, I mean, again, it's okay. The metatarsal, um, the heads of the metatarsals are not overlapped except for right here. You can see soft tissue overlap here as well, which is not ideal. Um, so, I mean, it's okay. Toes aren't the easiest thing because people can spread out their fingers. Toes are a little bit more of a challenge. And you can see this marker is added after the fact because literally this is all that was there. I added that marker um, because this is not acceptable. You have no idea what that marker would be. I don't even know why they would really put that in there like that. The lateral is the last image that we do. So on toes, when it is a lateral, this is referencing a lateral of the first digit. So if it's the first digit or the second, you're going to do a lateromedial lateral, meaning you're going through the lateral aspect of the first and second digit and exiting the medial. So lateromedial projection for the lateral on the first and second digit. When you're looking at the third, fourth, and fifth, it will be a mediolateral projection. Okay, so this is on page 230. This particular image is not the same as the one in the book, but they are referencing 6.47 for that. They just have an updated model. All right, so with this one, when it's lateromedial projection, you're going through the lateral aspect, exiting the medial. So the leg is turning inward. The knee would be going towards the other leg. So you rotate the leg and foot medially for first and second, even though the book says and also third. And you're rotating it laterally for third, fourth, and fifth. Your central ray is directed to the interphalangeal joint for the first digit and to proximal interphalangeal joint for digits 2 through 5. Okay, so if it's the first digit, your central ray is at the interphalangeal joint. And if it's second, third, fourth, or fifth digit, then you're to the proximal interphalangeal joint on any of those. Right, and that again is on page 230 of your textbook. When the book says, for third it's a lateral medial and I'm saying no, I would do a medial lateral, it really doesn't matter honestly because the OID is equal either way because of how and where that third toe is in the middle. So either direction you're going to have OID for that. This is showing you the lateral of the fourth digit. So I would say fourth and fifth are medial lateral as far as the projection. Third digit, like I said, can be either direction because the OID is the same. Central ray, like we said, is to interphalangeal joint for first digit to proximal interphalangeal joint for 2, 3, 4, or 5. And when that image is complete, this is a lateral toe. This is equivalent to 6.5 on page 230. So this is a lateromedial projection of the second digit. The digit should present in true lateral fashion. The interphalangeal and metatarsal phalangeal joints should appear open. The digit should be free of superimposition. Now that is a little challenging. This is definitely where tape or popsicle sticks or something is going to probably come in handy to help the patient separate their toes. Okay, you can see in the book they use gauze, they use tape to get everything out of the way. You probably don't want to tape the injured digit. You're trying to isolate the injured away from the other toes. Okay, so toes are a little bit tricky. Yes, I would definitely have gloves on to image the feet. Not because I think everybody's feet are dirty, but typically feet are sweaty. They're probably at times going to be bloody, sandy, you name it. They're just going to have something on them. So wearing gloves is likely to happen when we are doing toes and feet. All right, the tangential views. Remember, tangential means skimming a part. So the sesamoid bones, I said, could be fractured. So in order to view those, we do what's called a tangential projection, and that is on page 231. Remember, the sesamoid bones have names now in the foot. So they are the tibial and fibular sesamoid bones. And they show you that you can take an image of those with the patient either supine and dorsiflexing their foot, using, in this case, they're using a Velcro band to pull back on the toes. Or you can place the patient prone and put their toes on the image receptor and um, have them dorsiflex that way as well. But notice the central ray on both is just skimming through this section. All right, so the central ray is perpendicular to the IR and it's tangentially directed to the first metatarsal phalange joint. Now, that is totally dependent on how much dorsiflexion there is. If they're not able to achieve this, because ideally you would want the plantar surface at a 15 to 20 degree angle from vertical. All right, so this surface should be between 15 to 20 degrees from straight up and down, just like in here. If they reference if they're not able to do that, it is possible that you would have to angle more than that in order to achieve that 15 to 20 degree angle from vertical. This is the images that would come, which kind of funny to look at, but the medial, if this is the right, this would be the medial sesamoid. So this is the tibial sesamoid and fibular sesamoid. The sesamoids should be free of superimposition. And ideally you have the 3 metatarsals included in this. So if this is the first metatarsal, this would be second. Ideally it would be open a little bit more to reference the third. Um, but that is actually a nice image and those look good, but at times they actually can be fractured. Imaging of the foot. Now, when we image the foot, typically we have a routine just like we do with all body parts. Typically on a foot, we do an AP, or you could call that a dorsoplantar projection. We do an oblique, which is a 30 to 40 degree medial oblique, and we do a lateral, which is a medial lateral projection. A lot of times, notice that if the patient is ambulatory, they will do the AP and lateral weight bearing. So we'll look at that a little bit later, but what that means is you would take the image while the patient is standing to show, how the foot looks and behaves under pressure, and the pressure would be the patient's own body weight. All right, an AP foot, this is on page 232 of your textbook. With this, again, you're going to be able to identify any fractures, any dislocations, any joint space abnormalities, or soft tissue effusion. You can do foot for foreign body. The technique on the foot, I bet you could guess, is just like it is on a hand. So it's 65 kVp at 1.2 mass. So again, anatomy, really positions and techniques extremely similar to upper extremity. You would likely be on a 10 by 12 portrait. Again, long axis of the part running parallel to and with the long axis of the IR. I would suggest that you place the patient supine for this if it doesn't have to be a standing view. I would tell them to lie on their back. A lot of patients want to sit up and place their foot on the image receptor like this, but if they're sitting up, often what happens is they end up pushing the IR and their foot out because of the pressure when their knee is over their foot when they're sitting up. So if you lay them down, they tend to hold still a lot better. And if it does still move, excuse me, what you can do is put a sandbag here so that the IR doesn't slide. Okay. Now, we had talked about the longitudinal arch and the fact that we have to evaluate the foot from the medial aspect to look at the arch. And the reason for that is because your central ray angle is totally dependent on the longitudinal arch. So if the patient has a low arch, like if they're flat foot or pretty much flat foot, then you have a 5-degree or less angle on your central ray. If they have a high arch, a really high arch, then you're angling 15 degrees, and these are all going posterior, meaning towards the calcaneus. Okay, so flat foot about 5 degrees or less. A really high arch would be 15. Everybody else, what we would consider a normal arch, is going to have a 10-degree angle. And the reason we angle is to be perpendicular to the metatarsals. Remember we said that dependent on that longitudinal arch, these are going to either be, these are either going to, let me get a pen here. Ideally, you want to be perpendicular. So if your metatarsals are like that, then that central ray is perpendicular to that. But depending if they're really flat foot and they go like this, you don't need much of an angle at all. Or if they're really high, then you need more of an angle because you're trying to be perpendicular to the metatarsals. All right, so perpendicular to the metatarsals is what determines the angle on the tube. So it's somewhere between 5 and 15 degrees, totally dependent on the longitudinal arch. The central ray is to the base of the third metatarsal. So a little bit different with that because with the hand it was the third metacarpophalangeal joint. Now we want to find the third digit, and you're coming to the base of the third metatarsal. Now, in this picture, I'm not sure why they do this, but this is definitely second. I would argue you want to be in line with the third metatarsal. So CR is the base of the third metatarsal, 65 at 1.2. Marker still goes to the right of the part if it's a right, and to the left of the part if it's a left. If done correctly, then you would have the entire foot visualized, all phalanges, all the metatarsals, navicular, cuneiforms, cuboid. You're visualizing all of that. You don't get a good visual of the other bones in the foot though, because the tibia and the fibula are in there with the ankle and the lower extremity, so it's hard to isolate those other bones, especially on the AP. If you are perpendicular to the metatarsals, then your metatarsal phalangeal joints should be open. All right, and this, like I said, this is figure 6.57 on 232, and this is actually a really nice image of the AP foot. Next, we would do our 30 to 40 degree medial oblique. And this is on 233. Same collimation, still portrait, still 65 at 1.2. But now what we do is we tell the patient to take their entire leg and rotate the plantar surface so that it's 30 to 40 degrees from the plane or the, the top of the image receptor. Okay. It also tells you in the book that the general plane of the dorsum of the foot should be parallel to the IR and perpendicular to the CR. Okay, so the dorsum, the top aspect of the foot, should be parallel to your image receptor and perpendicular to the CR. The central ray is the same. It's the base of the third metatarsal. Now this, they do a much better job. You can actually see third, and you come all the way down, and it's right there. Okay. I typically tell you that, visualizing that sometimes is hard, but what you can usually palpate is the tuberosity at the base of the fifth metatarsal. And when you do that, especially on this puts that tuberosity in profile. I'll show you on the next image. But if you can palpate that fifth metatarsal tuberosity, the way the bones of the foot go is typically, it's easier for me to draw this. The bones tend to go slightly, like when you have the tuberosity here, okay, the bones tend to go at a slight angle. So if you can palpate this, then you usually find the third, and if you come down, you're going to be just usually in front of that tuberosity. So this right here being the central ray actually looks really nice, because my guess is that that tuberosity at the base of the fifth is probably right here. All right. It's easier in the next image, I promise. Let me get rid of all these. All right, so if we move forward with this is the tuberosity at the base. But see how they, like if you look at the base of the third is here, which is in front of the tuberosity here because they're kind of at an angle. So you find third digit, follow that down. Right here would be your central ray. All right, so you're getting the entire foot. Third through fifth metatarsals are free of superimposition. So first and second, there's still some superimposition, but third, fourth, and fifth, with the proper degree of obliquity, there is no superimposition. The fifth metatarsal tuberosity is in profile, and this is a very common fracture site. Very common to fracture that. A lot of your images under the anatomy demonstrated, it will say must demonstrate tuberosity at the base of the fifth metatarsal. Okay. All right, and then we do our last image is a medial-lateral projection of the foot. All right, so this is a lateral on page 234. Your technique doesn't change. Your IR does need to move so that the long axis of the part goes with the long axis of the IR. So it is possible that you turn your image receptor to the patient in this lateral position. You're still at a 40-inch SID. You're still collimated. The book seems to tell you 8 by 10, but I would tell you 10 by 12. And it's portrait to the long axis of the IR. All right, even when they show you in the book, they reference it as portrait, but they're looking at the long axis of this. So to us, it would probably look landscape. All right, 65 at 1.2. Patient is going to roll the affected leg outward, flex their knee, and roll it about 45 degrees. If they're able to, you'd want to dorsiflex the foot because your goal is to get the plantar surface perpendicular to the IR. So this is the plantar surface. If you struggle with that, just think of plantar warts are typically on the bottom of the foot. So this is dorsum up here, plantar surface here, and you want this surface perpendicular to the IR. You don't want to over-rotate the foot. And the central ray on this is directed to the medial cuneiform. So, like I told you with hand, okay, with hand, we were at the third metacarpophalangeal joint. And then when we rolled the patient into their fan lateral, now our CR was at second metacarpophalangeal joint. So we've been, the past two images were at the base of the third metatarsal. And when you roll the foot on its side, now you end up being on the medial cuneiform, which is still in line with not the tuberosity, the base of the third metatarsal. If we look at that, you're demonstrating the entire foot. You can see that the plantar surface does look as if it was perpendicular to the IR. It is a really nice lateral foot. You should see the entire foot, and you need 1 inch of the distal tibia and fibula. Okay, so right here. Just like when we did hand, we needed 1 inch of the distal radius and ulna. So now we need 1 inch of the distal tibia and fibula. The tibiotalar joint right here is demonstrated. The metatarsals should be superimposed. I mean, they're not all the way superimposed. It is pretty good. Optimal exposure factors, meaning you should be able to see soft tissue, bone trabeculi. Markers should be present before exposure, not annotated after. All right, you can tell that the foot is lateral because this tibiotalar joint is open. All right, so that actually looks pretty good on there. When we look at the medial or first cuneiform, that is this right here. So it's in line with the base of the third metatarsal. It's just that you're coming up on top of the foot now, so it puts you right there instead of when we're looking at the foot in an AP position. Okay, and again, this is on page 234 of your textbook. So 3 views for the foot: AP or dorsoplantar, a 30 to 40 degree medial oblique, and a lateral, which technically it is a medial-lateral projection. So figure 6.64 in your book, we do not do a lateral-medial, only 6.63. We talked about the fact that if the patient is ambulatory, ideally they are done weight-bearing. So the AP and the lateral are typically done weight-bearing if they are walkie-talkie. If it's a trauma patient and they're not able to stand, then we are not going to stand them to do these images. Okay, these are actually on 235 and 236. And what the weight-bearing does is demonstrates the bones when they're under pressure, under the full weight of the patient. All right, so it shows the longitudinal arches, it shows how the bones behave under the patient's full body weight. You'd still be at a 40-inch SID, and ideally, they typically will order these bilateral, but if it was just a unilateral foot, your technique would be no different. It'd be 65 at 1.2. You would have the IR run parallel with the long axis of the foot if it was one foot, a unilateral foot. If they did both feet at the same time for bilateral, then you would likely turn the IR landscape and do both feet. Central ray is angled 15 degrees posteriorly, and if it is bilateral feet, then it's between both of them at the level of the base of the third metatarsal. I'm sorry, I'm thinking unilateral. If it was unilateral, it would be the same and be at the base of the third metatarsal. If it's bilateral, you're basically in between both feet at the base of all the metatarsals. So they're in between the bases of the metatarsals by imaging right here for this AP. All right, it is a horizontal beam. I'm sorry, for the lateral. Whew, I'm so sorry. All right, let's start again. AP weight bearing. This is bilateral, which the central ray is angled. You can see that 15 degrees posteriorly, and it's placed between both feet at the base of the metatarsals. If it was 1 foot unilateral, you would still angle 15 posterior, but you would center to the base of the third metatarsal on 1 foot. Since they're doing both, they have the IR placed landscape with both feet on there. If it was 1, you would turn this so that it would run portrait with the long axis of the foot. When we do the lateral image, it is a horizontal beam. You would be at a 40-inch SID, likely on 10 by 12. The patient would stand erect with their full weight on that foot, and the central ray is horizontal to the level of the base of the third metatarsal. Ideally, it would be on medial cuneiform, just like a lateral foot would be. Okay, so medial cuneiform, horizontal beam, weight bearing. With the AP, the evaluation criteria on the bilateral weight bearing, notice it says bilateral feet are demonstrated. The phalanges and the metatarsals are not rotated. Now, this picture is an adult. The picture in the book on 235 is actually a child. You can see the epiphyseal plates, meaning that the bones are still growing. But you should demonstrate bilateral feet from soft tissue surrounding the phalanges to the distal portion of the talus. So they do have a pretty decent amount there, but usually they're done bilateral just so that they can compare both feet to each other. That's typically why it is bilateral. Some orthopedic docs, though, I have seen will order a unilateral, especially if it's for follow-up. So that's the AP. And then this would be the lateral. This is figure 6.7 on page 236. You can see that this is the table or whatever they were standing on. You can actually visualize that. So this is a horizontal beam. Central ray is medial cuneiform or at the level of the base of the third, but ideally when we do a lateral, we say it's on medial cuneiform. So it would be the same on a weight-bearing lateral foot. So you have to demonstrate the entire foot with a minimum 1 inch of distal tib fib, just like a non-weight bearing. So that's not enough, really, of the distal tib fib. Okay? And the longitudinal arch typically has to be demonstrated on this image. All right, so we have looked at toes, we've looked at foot, and we've looked at the anatomy of all of that, and we've also seen weight-bearing images. So I hope that this was enlightening. I hope that you were able to take notes, and please make note of any questions or concerns you might have, any questions about the positioning or the images. There are positioning videos for you to view, and if you bring those questions to class, next time we meet, we will take care of anything that's confusing or doesn't make sense. Alrighty, so until then, I hope you guys have a great rest of your day, and I will see you soon.